So I'm going to talk a little bit about palliative care and surgery, and I think what I hope to achieve at the end of the session is for you guys to have a better understanding of what we actually do, who our patient population is, why we do the things that we do, to really be able to appreciate the intersection between surgery and palliative care, where the overlaps are, where the opportunities are. And lastly, to really briefly go over what resources we actually have available here at Mount Sinai. So that's sort of my goal. It's a little ambitious, and I hope to be able to cover this within the hour. Each one of these topics alone could take an hour, but I'll do my best to sort of cover that and then leave a little bit of time for questions at the very end. So this definition of palliative care was actually tested with the public and endorsed by the public. And when the public was asked, based on this definition of palliative care, whether they will want palliative care when they actually have a serious illness, 90 to 95% of the public said yes. And the way this is phrased is palliative care is a specialized medical care for patients with serious illness. Keep in mind, it's not all about end of care here. It's focused on providing patients with relief from symptoms, pain, and stress of a serious illness, regardless of what the diagnosis is. And the goal is about improving the quality of life for the patient-family unit. So we don't focus on the patient alone. We feel like in order to treat the patient, we need to focus on the family as well. They're the caregivers, they're the ones who are providing the care, and they're part of the decision-making team. Palliative care is provided by a team of doctors, nurses, and other specialists who work together with the patient's other doctors to provide an extra layer of support. That's something we stress a lot. We're there as an additional layer, and it's appropriate at any age and at any stage of serious illness, and it can be provided with curative treatment. In fact, if you look at actually our census, about a third to half of our census are in patients who actually potentially are going to leave the hospital and who are actually going to do very, very well. We're there to really provide that extra layer of support to provide symptom management to help them with the transition planning. So there's two models here. On top, you see the old model of life-prolonging care. You do life-prolonging care until this magic point in time, which we all know when that will be, and they transition automatically to this hospice benefit, which is really an insurance benefit that provides hospice care at the last 6 months of life. The problem is none of us really could define prognosis well enough to know when they actually jump over this wall and they actually are appropriate for hospice. So what you actually see is that the people who are actually enrolled in hospice have a length of stay in hospice, not of 6 months, of days to maybe a week at the most. And that's a problem. It's a benefit that they have that no one taps into until the very, very end. And there is a lot to be gained from the benefit. So the new model looks at integrating palliative care as life-prolonging treatments are actually available. So palliative care may have a very small role at the very beginning when there are a lot of life-prolonging options or disease-directed treatments. And palliative care may start playing a much bigger role as these treatments become more limited, and at some point transition them over to hospice, which is followed by a 13-month bereavement period of surveillance for the family after the patient dies. Keep in mind, I'm not advocating that a palliative care specialist have to be involved from the very beginning. There are a lot of palliative care related issues that can be addressed by primary care providers and providers like yourself. And some of this has actually been incorporated into the daily work that we do already. You know, if someone were to come in with abdominal pain while we're working them up, we treat them for their pain. You're providing palliative care. The same thing is true if someone were to walk in to the emergency room with chest pain. Standard protocol requires that they get some morphine. And that was really for the alleviation of pain, although the later data shows that those people who actually do get the treatment, which includes morphine, did better overall in morbidity and mortality. So some of this has already been included in the standard of care, and it's just an awareness that palliative care is available and should be included early on. So what does palliative care do? I told you a little bit about symptom management. We address 3 main domains: the physical symptoms, the emotional, spiritual symptoms. We actually offer to help with communication and decision making. And lastly, we help with coordination with regards to continuity of care and really making available support for practical needs for both the patient and the family, especially as they transition across various different settings in the health system. And if you were to look at these three domains, it actually, the data that I'm going to show you a little later, showing you the evidence of how we actually have been able to assist with these three domains, show that we actually impact 4 of the 6 domains of quality if we were to look at the sort of the six sigma datas of quality. We actually are patient-centered, it is safe, it's beneficial, and it's efficient. So what exactly is it that we do? For the patient, we provide symptom management, we help reduce the burden of the illness, we help strengthen relationship, and I'll show you a little later, about the stuff that our art therapist does to help strengthen relationships that the patient may have with the family. We help them achieve a sense of control, and we avoid prolonged dying process. For the family, we help reduce the burden of illness, and we help support them, and most importantly, we actually help them undergo anticipatory bereavement. For the physician, we help you manage a patient's pain and symptoms. There's the thought of helping to reduce the risk of interventions if that's not what the family will want. And then really to help provide patient and family education based on the materials and the knowledge you help us understand. And our role is to help the patient and family understand what's going on. We respect patient autonomy, and we really arrange if and when the patient is dying, we arrange for the care of the dying patient who may be at the very end of life. I want to walk you through a case of Mrs. G, and I'm going to be referring back to Mrs. G as we go further. So Mrs. G was very recently diagnosed with colon cancer. She initially declined surgery and was placed on bi-weekly transfusions. I actually met her about 7 years ago in my outpatient practice in geriatrics. So she actually came in for a second opinion, trying to figure out, given her age, she should get surgery. What I actually tapped into was actually my palliative care skills. We really spoke about her recent medical conditions and what her goals are. She's 96. Her goals had always been to be able to entertain. She has a large family, and she prides herself in being able to prepare a meal for 20, 30 people. We sort of spoke a little bit about, well, that may not be possible given her declining physical state. She voiced that she enjoys, if she can't prepare, she could cater, but she enjoys having the family around, and that's the most meaningful thing to her. She also told me that it was very burdensome for her to come in here twice a week to get those transfusions. First, she spends a day in the transfusion center. The next day, she's recuperating because she's so fatigued. And day 3 is really the day that she gets some value out of these transfusions. So maybe twice, 2 days, 3 days a week, she gets to do something. And she felt that that has really become very burdensome. So we talked a lot, and based on sort of what her goals are, surgery was actually recommended based on risk, benefit, and the goals of the patient. She did very well after surgery. She actually even tolerated some chemotherapy. She went on for a year, very well, came back again with melanoma. We discussed her goals again. It hasn't changed. She had another surgery. The goals of the surgery have mainly been palliative in nature to really focus on treating her symptoms so she could avoid these transfusions that had bothered her so much. But this second time, she didn't tolerate the chemo. She gave it a try. It was too burdensome. She stopped. 4 months later, she actually took a trip, and I got a call from the daughter that she wasn't feeling very well. They wanted to come back here for treatment. She came here. She ended up directly being admitted to the hospital. And we talked about sort of her medical conditions at that time. She had acute kidney injury. She was dehydrated. She had a recurrence. She was bleeding. And while we can fix each and every single one of these problems, we did not think that she was going to be able to to attain her previous goal of being able to entertain people the way she was able to do before. She wants to make sure we don't prolong her dying process. We allow her to die at home with her family at her bedside. And that was exactly what we did. We made some recommendations. We encouraged the family to come in, spend time with her. We stopped fluid repletion and maximized her medications for comfort. And the reason behind the stopping of the fluid repletion was really for symptomatic relief. She was getting fluid overloaded. Her body could not take the fluid that we are actually giving her. Her lungs started getting wet. She was edematous. And for symptom relief, we felt it was best that we actually cut back on her fluid so we don't end up having to give her Lasix to chase the fluid that we were giving her. She got evaluated for hospice, and she was issued a home DNR. She died peacefully at home about 3 days after she was discharged with her family at the bedside. So how did palliative care help here? We clarified goals. We eliminated any ambiguity that may have existed. And the decision was made by her. The burden was taken off the family. She was very clear what her goals were. We reviewed those decisions that she made and decided and make sure that the treatments that were provided to her actually match her goals. We actively treated her symptoms. We allowed her to die at home in a manner according to her wishes. And in the process of doing so, we probably eliminated a lot of unnecessary tests, and we probably cut costs. The alternative scenario you can imagine would have been more procedures, because each one of those isolated issues probably could have been treated, but it would not have helped her attain her goal. More tubes, more medication, probably a longer ICU stay if she made it to the ICU until she died. She probably would have died in the ICU and not at home. So next, with that case in mind, I want to show you some data on palliative care's impact on quality and cost. And I sort of want to start with Mark Twain's quote, "Do the right thing. It will gratify some people and astonish the rest." Palliative care really started as a do the right thing. We felt that there were things we wanted to be advocates for our patients. There were things that are being done that may not be consistent with the patient's wishes. We started looking at costs really as sort of a way to justify that we are going to improve quality and not increase the cost of healthcare. And to our surprise, we actually found that by doing the right thing and doing what the patients want, we actually decrease costs. But that was completely an incidental finding. It wasn't something that we started out to do. Our initial purpose was really to improve quality. So if we were to really look at the current healthcare system and if we wanted to reduce the value of healthcare, there's really two things that we could do. We could either improve quality, which is sort of the numerator here, or decrease the cost, both of which will actually improve the value of healthcare. And I'm going to show you some data that palliative care actually improved prognosis. And this is all completely secondary outcome data, not something that none of these studies were intended to sort of look at prognosis. But I'm going to show you some of the secondary data that shows that palliative care may actually improve quality and improve the value by actually improving prognosis. How do we actually improve quality? It's all the stuff that we do. We help with symptoms, we help with quality of life, we improve satisfaction, bereavement outcomes, and we match the goals, the care to the patient's predetermined goals. And in the process of doing all that, we were able to reduce hospital costs. Going back to Mrs. G, we know her goals, and when we realized that whatever we do, we're not going to attain or achieve what she was hoping for, we actually helped to improve her quality of life, did what she wanted, and in the process of doing so, she never ended up in the ICU. She ended up home with her loved ones, with her symptoms managed, and died peacefully at home. So this is sort of the initial work that palliative care had done in terms of satisfaction. It was a satisfaction data given to the families of patients who actually died in the hospital. And they were really looking at what it is that was missing from the hospital stay. This was done by Joan Tino, published in JAMA in 2004. And what families complained of was that they don't have enough contact with physicians, they don't get enough emotional support for both the patient and the family, they don't have enough information about what to expect if they were to die, and they don't have enough help with symptoms. Based on this, one of my colleagues here actually looked comparing usual care to palliative care. And this is a retrospective study looking at, so for the patients who actually got usual care and compared to palliative care, and then interviewing their families to see if they actually felt that they received the emotional support and the self-efficacy of the family, the supports about what to expect, how to treat symptoms if they were to come up. And you see a huge variation and an improvement if palliative care was involved. So for this group here, if palliative care was involved, there were more emotional and spiritual needs met. So 65% of the group who received palliative care had their emotional and spiritual needs met, compared to 35% who actually gets usual care. And if you were to look at the second group, 66% of those who received palliative care actually were more confident in one of these domains at the end of life, compared to 44% of those who actually get usual care. So just some data on sort of how we may be impacting quality. This is sort of Temel's article that actually hit the New England Journal of Medicine a couple years back, looking at early palliative care for non-small cell lung cancer patients. And what was actually done, it was a randomized controlled trial. Patients were either randomized to getting standard cancer care with palliative care co-management, or they were getting standard cancer care only. Those who are actually getting standard cancer care only can actually get palliative care if their physician actually requests for one, but it's not a co-management model. What they actually found was that there's an improvement in quality of life. There was actually a reduction in major depression. There was a decrease in the aggressiveness of the treatment. So if we're really looking at the people who are actually at the very end of life, they were less likely to get chemos 2 weeks before they die. They were more likely to get hospice and less likely to get hospitalized. We were able to keep these patients at home. And surprisingly, as a secondary outcome, you found that there was improved survival, 11.6 months versus 8.9 months. And that's actually pretty significant, because if we were to think about what FDA actually approves for a cancer drug, it's a 3-month life extension. And we're almost there just with palliative care alone. So this is not insignificant if we were looking at the bigger picture of, which chemotherapy actually gets approved. So anybody with 3 months or longer survival will get approved by FDA as a chemo treatment that is now approved for use. This is a little older data looking at hospice in general, and that people who actually were enrolled in hospice for even at least a day, actually, if you were to look at them as a cohort group, had added survival. Some of them didn't reach statistical significance, but it's actually pretty impressive. There are certain diseases that actually have more to gain by being in hospice. And by providing the care that they really want, decreasing some of the interventions which may have side effects, they actually lived longer. So what is the consequence of late referrals? There's actually data saying that late referrals, especially for bereaved caregivers, and this is data comparing those who actually died at home versus the one that died in the hospital. For those who actually received their end-of-life care in the ICU, that's associated with a 5-time family risk of PTSD. For those who actually get their end-of-life care in the hospital, there's an associated risk of 8.8 times for a prolonged grief disorder. So it's just something, again, sort of talking a little bit about quality, about what our patients and our caregiver, our family want, gives us some perspective in terms of what we can do to help them. So moving on to cost. If we were to think about the business of modern medicine today, what are our cost drivers? We hospitalize. We don't have a 24/7 service, so if someone were to come in late at night, as in the case of Mrs. G at 7 p.m. with an issue, the only place where she can go to receive the care she needs is the hospital. We refer to our colleagues. A couple of years back, there was even more the practice of defensive medicine. If we're not 100% sure, we want to make sure that diagnosis is 100% accurate. We ask our colleagues to help us verify. We do tests and procedures and treatments. We rely a lot on our tests, procedures, and treatment, and maybe a little less compared to a decade or two ago on our clinical judgment. There are financial disinhibitives inhibiting coordinating communication about goals. It takes time. We don't get reimbursed for those conversations. We have a fragmented multi-specialty care with a lack of primary care coordination. And there's a lack of training on the needs of the seriously ill, including symptom management, how do we communicate, how do we coordinate transitions. This is just a cartoon from the Cartoon Bank depicting some of the things that we see in modern practice. I mean, although we see that this is thorn-like in appearance, clearly the doctor feels that they need to order a battery test to verify this is indeed a thorn. So how do we reduce costs? If we actually are very efficient about our conversations about goals, not only could we improve quality, but there's data now showing that we can actually reduce costs. So this is a prospective multi-center study of 332 seriously ill cancer patients. If they were able to recall any conversation about goals or prognosis, there was an association with better quality of dying and death, lower risk of complicated grief and bereavement, and less hospital and ICU care. So this is the data that you see here. So the group here who actually have recalled that they had an end-of-life care discussion, and these end-of-life care discussions are not necessarily with palliative care, it's with any provider. They actually noted that they were less likely to end up in the ICU in the last weeks of before death. They were less likely to end up being on a prolonged ventilator, and they were less likely to be resuscitated. They're more likely to end up in hospice and staying in hospice for at least a week before they die. And we were not quite surprised by the fact that chemotherapy and feeding tube actually did not reach statistical significance, because those issues actually are much more complicated, especially on the issue of feeding. There are cultural, religious factors that come into play. This is actually data from my mentor, looking at the palliative care consultative service across 8 US hospitals. And what you see here is that for the patients who actually get discharged alive, per admission, if palliative care was involved, there was a savings of about $1,500. There was a savings in terms of ICU because they were less likely to end up in ICU, or if they end up in ICU, their stay there is usually a little shorter, of over $5,000. Pharmacy costs differ too greatly. If they were to die in the hospital, the savings were even greater. Almost $7,000 per admission for those who palliative care was involved in, $7,000 in ICU savings. And this is, the data I'm presenting now is actually data across the 8 hospitals. I will tell you, if I were to actually present you the Mount Sinai data, because Mount Sinai happened to be one of these sites, the cost saving was even greater than what you see here. These are Kaiser data, looking at randomized controlled clinical trials. The column on the left is outpatient. The column on the right is inpatient. Again, documenting that there are savings. There are equal survival, better communication, better quality of life care, and a savings that it wasn't what we had initially intended to expect. But clearly, when the goals are matched, treatments are matched their goals, there is actually appropriate care and overall value of healthcare. How else can we actually decrease the cost? We actually allow for provision of higher quality care in appropriate and often less costly settings. So if you were to look at this study done for patients with heart failure, COPD, and cancer, they actually got a home palliative care intervention. While they got more home visits, so this is the bar of Pall Care intervention in blue, their visits to the emergency room, to the hospital, to subacute nursing facilities actually decrease. And if we were to look at the cost, these 3, the ED, the hospital, and the subacute nursing facilities are where the highest costs are. The cost of actually having an extra visit at the home is much less than any of these areas. There's also data showing that if patients actually use palliative care or hospice, and services are actually set up before discharge, there's a dramatic decrease in readmission data. And this is sort of what actually shows. Patients who actually end up going to hospice have a 4.6% chance of being readmitted. Patient who gets home-based palliative care has an 8.3% chance. Routine home health care has about 13.3%. And if they were to go home with no home care, a quarter of them actually end up coming back to the hospital. So I hope I showed you some evidence about how palliative care can improve quality and how palliative care, by improving quality, actually can decrease costs. I want to talk a little bit about surgical palliative care, where the intersections are and where the opportunities are. You may be surprised that Balfour Mount, a surgeon, a Canadian surgeon, was actually the first to coin the term palliative care. It wasn't coined by an internist. It wasn't coined by palliative care physicians. It was actually a surgeon. And he's actually known as the father of palliative care in North America. And he came up with the term palliative care because he found it to be a terminology that easily translatable between English and French. Whereas hospice was not a terminology that was easily understood. And he described palliative care to be a comprehensive, interdisciplinary, patient-centered care that provides symptom relief to dying patients. And if we were to look at the early surgical operations, they were all palliative in nature. The pancreatical duodenectomy, the gastrojejunostomy, the Hallstatt radical mastectomy were all attempts really to palliate. And as the techniques improve, there were actually the techniques are now able to actually decrease morbidity and mortality, but they initially started as palliative surgical procedures. I was very surprised to find that the coronary artery bypass was started out as a palliative procedure. The initial intent of the very early coronary bypass procedures was actually attempted to alleviate chest pain. And where in surgery do we actually see the multidisciplinary palliative care team? We actually see these in burn and trauma patients. They're actually in burn centers and trauma centers. They're actually palliative care teams that actually assist in the co-management from the very beginning, regardless of whether the patient actually will do very well or do very poorly. And this is a quote from Bill Roth. I hope we have taken another good step, referring to gastrectomy, towards securing unfortunate people hitherto regarded as incurable, or if there should be recurrences of cancer, at least alleviating their suffering for a time. This is what you see nowadays. This is a young woman with locally advanced pancreatic cancer presenting with abdominal pain, nausea, and vomiting. And we would discuss with the surgeons together with our interventional group as well about what is the best approach to actually help her alleviate her symptoms. So the core principles of surgical palliative care really centers around alleviating suffering and providing support. And the best way to do this is through communications. Before surgery, there's an opportunity to sort of assist with the communication in the process of informed consent. And the other way to communicate is to really help the patients in terms of decision making, even before we get to the point of thinking that the surgery is the most appropriate next step. The question is, just because we can operate, should we? Eric Cassell in 1982 described this in his writing on the nature of suffering, talks about the relief of suffering and the cure of disease as twin obligations of the medical profession, truly dedicated to the care of the sick. Physicians' failure to understand the nature of suffering can result in medical interventions that, though technically adequate, not only fails to relieve suffering, but becomes a source of suffering itself. And that's something that we should think about moving forward. This is by Dr. Newland on a surgeon's reflection on the care of the dying. And what he says is self-knowledge guides us in knowing when to give up on the hope of combating a disease and when to soldier on. It prevents us from making decisions in which the real aim is to shore up our own personal defenses against insecurity. It shows us the source of our own fears of death and lessens their acuteness. It outs our fear of passivity and impotence into perspective so that each failure of therapy is not the expense of reason. Most importantly, it enables us to fulfill our pastoral role as surgeons. This, and not the technology, is what being a doctor is all about. So let's go back and talk a little bit about the preoperative discussions that you all have before surgery. I think there's a lot of emphasis, and I think everybody does a really great job making sure that it's frank and open about the patient's condition, the need for surgery, what the alternatives are, the anticipated risks and benefits of the procedure. What we don't necessarily do a great job with is really the discussion of morbidity or the long-term effects of the patient's pre-existing quality of life. We focus on the risk of bleeding, the risk and the need of supportive mechanical ventilations, but I think this is the area where we don't necessarily do a great job about. Is this going to impact their quality of life moving forward? How would it actually change? Are they going to be able to go home after this procedure? Or would they actually have to go to a nursing facility? Keep in mind that whatever plan that's chosen is not permanent. We could change it at any time. Remember Mrs. G? We reviewed it at every crossroad. Every time there is an event, we review her goals, and we want to make sure she hasn't changed her mind about what she wants. So it's not permanent. But what's important to note that we have to anticipate the possibility of a poor response to surgery or the potential worsening of an underlying illness and really elicit what the patient wants beforehand. So we know what to do. And there's nothing wrong with a time-limited trial. I want to sort of differentiate between fixing the problem and reaching a goal. Let's take a look at what we hear from patients and family. But doctor, he's a fighter. I don't want to die. I want to go to Aruba next month. I want to go home. Nothing here, any of these four statements, talks about, doctor, I want you to fix my kidneys. Doctor, can you fix my arteries? It's all about what they want in life, about reaching something. So what we need to really match up is we need to determine whether fixing the problem is actually going to help them reach their goal when we decide, should we operate? This is another way of looking at it. So if you were to look at the spectrum, this is the best outcome. On this end of the spectrum is the worst outcome. This is what the patient and family hopes for. This is what our estimate of what the prognosis would be in terms of our ability to help them reach their goal by fixing the problem. And when we have these goals of care discussions, we actually aim at achieving an area of overlap. When the patient is doing very well, this may be a complete overlap. Right? Fixing the problem actually helps them achieve their goals. So if someone were to come in with appendicitis and we decide that that's appropriate to sort of operate on, and we know we're going to get them better, we achieve their goals, and the overlap is actually exactly the same. There are also times when that overlap does not exist because the patient wants you to allow the loved one or the patient wants you to allow the patient to live forever. And you know that they're septic, they're very sick, and there's no way, no matter what we fix, we could fix the numbers, we could treat the infection, we know that their life expectancy is very limited. So the area of overlap becomes very, very small, if not at all. And these conversation aims at trying to figure out, can we reach an area of overlap so that the goals actually match? So in the case of Mrs. G, remember her initial goal was to be able to go back and entertain. But when that goal became unattainable, there was a second goal, a second overlap that we were able to achieve, and that was making sure that her symptoms were controlled and making sure that she dies at home. And how do we do this? How do we communicate effectively? We take into consideration the language, verbal and nonverbal. We understand the patient's needs, and we appeal to the needs of the patient. So I want to show you a quick clip, and I'll tell you why I'm showing this. Hold on. Let me stop this.
That's basically it. Your kidneys aren't responding to the medication anymore. I'm afraid we're going to have to start you on dialysis.
I'm not a big fan of dialysis.
Yeah, unfortunately, we don't really have a choice.
Well, actually, I do have a choice.
certain things you never expect to come out of a person's mouth.
I think I'm ready to die.
I bet a ton of bricks for Dr. Dorian. Can I get that pen back?
It's an illustration of something we take for granted, that when someone actually has renal failure, kidney injury, that we offer dialysis. But we want to make sure that's actually what the patient wants. She clearly has already thought about this, and it may not be consistent with what she will want, what her goals are. So it's really important. I chose dialysis in particular because it's something that millions of patients are actually on it. They do very well, but there are actually a population of patients who would choose rather not to be on it and find it to be very burdensome and a source of suffering. And when we communicate, we want to make sure that we actually give the adequate amount of information. Too much or too little information, as you see here, can actually increase confusion. Something to just keep in mind. We need to pay attention to our choice of language, because there are actually language about goals with unintended consequences. Do you want us to do everything possible? I don't think I would ever say no to that question. Yes, I will want you to do everything possible. Do you want us to resuscitate your loved one? It's already framed in such a way that the no almost imposes a sense of guilt, right? There's really no hope. There is always hope. It's about redefining hope. We never take away anybody's hope. It's about what they're hoping for when we can no longer achieve the initial goals. Will you agree to withdraw care? Care is always provided, okay? I personally would never say yes to that question. Your loved one expired or passed. We don't have an expiration date stamped on us. They don't pass. Our loved ones die. And it's very important to actually use the accurate language. Some better language to use about goals of care is we want to give you the best care possible until the day you die. Will your loved one want to die naturally when that time comes? So that is something I'm going to show you another clip that's very important, because if they want to die naturally, a DNR is probably appropriate, because DNR is intervening with the process of dying naturally. Okay? And DNR does not mean do not treat. It really applies only in the situation of a cardiac arrest, so it really only comes into play when the patient is dying. We will concentrate on improving your quality of life. We want to help you live meaningfully in the time that you have. We could shift our focus, the focus of our efforts, toward maximizing your quality of life. You see how the difference in terms of how we phrase things makes a huge difference in terms of the support, the sense of hope that we give our patients. So this is actually another video.
Brenda, good to see you. How's it been for the past couple of weeks off the chemo?
It's kind of nice. It's comfortable.
Wonderful.
Yeah, I'm liking it.
Okay. Well, so it sounds like for right now, we're doing okay.
Yeah.
So I have one other thing that I wanted to bring up that's kind of a planning for the future kind of thing. So, at the point when death is really close, have you given any thought to what kind of medical care you would want to have? I know that's a hard one to think about.
Yeah. I just know one thing, and that is I don't want to die in a hospital.
Mm-hmm.
I don't want to leave my home.
Mm-hmm.
Can you arrange that?
So you want to be at home?
I do.
So you know what? There are some things I can do to help that and to help make that happen. And one of the things is that, when death comes, I think what we should do is focus on making it natural and peaceful. And there are some things we can do to do that. And one of them actually is about CPR, is that, I actually would recommend that we not do CPR at the time of death, that we allow you to go naturally.
And that's the alternative to being hooked up on machines and hospital bound.
That is the alternative. And I think it's a better alternative.
So do I. That's what I want.
Okay. I can make that happen.
These are sort of the type of conversations that we actually have. And it's about the type of language we use. And it's all about matching whatever the care plan is to the patient's wishes and goals. Language and communication, it's about respect. What a lot of our patients do when they come into the hospital is their control is taken out of their hands. They don't decide when they want to take the medications, when they want to eat. They feel that their ability to decide is weakened. Their control is jeopardized. No one considers or consults them. They don't feel that their feelings count. They feel that they're defeated, powerless, and inferior. And some of the things that we do is we empower them and try to give them a sense of control back. It's not what you say, John, it's how you say it. So I want to sort of have you guys think a little bit about, I don't think that palliative care has to be involved for every single case of serious illness, but to really recognize that you can also provide some of these palliative care communication techniques early on. But feel free to call us. If there's complex decision making, there's unresolved pain, you need help with psychosocial, cultural, or spiritual needs. If there are rehospitalizations with a very unclear goal and a family that's going around and around in circles, use us as a resource. Before I move on to tell you about what we have available here, I want to sort of talk a little bit about a couple of myths about palliative care. Before we go into a meeting, we don't know what we're going to say. We don't lead, we moderate the meeting, but the family tells us what the plan is going to be. Okay? We actually try to elicit what their goals are and then try to help align their treatments with the goals. So I've often been asked sometimes, what are you going to tell the family? And I really don't know what I'm going to tell the family. It's a matter of where that conversation goes and what they tell me dictates what I may tell the family. We're not here to talk anybody out of surgery or out of a procedure after they're consented. We will support you and the family and the patient through the procedure. And we may actually help to explore the goals if the surgery does not go as anticipated, so that we know what their goals are. Should the surgery don't go well, or should they have a complication after the surgery? And our team does not get DNRs. That's what we get called a lot for. Oh, can you guys help us get a DNR? We have a difficult family who is refusing to consent to a DNR. If the DNR makes sense and the big picture of the patient's goals after the conversation, there will be a DNR in the chart. But if it's not, there will not be a DNR. What we can help with is the conversation, not with obtaining a DNR. So I sort of just want to make sure that we clear ourselves in terms of some of these myths that we get from all over the hospital in terms of what it is that we do. So let me wrap up with telling you a little bit about what's new in palliative care, and then I'll open it up for any questions. So for those of you who may not know, we actually have a palliative care unit that opened 2 years ago. It's located on KP6. We have 13 beds there. We have actually entered a contract, a business contract with hospice, BNS Hospice. So if there are patients in the hospital who are actively dying and they are symptomatic, they actually can be enrolled into a hospice bed here on KP6. Okay. Keep in mind the key point is symptomatic, because most of hospice is delivered at home. 80% of hospice is home hospice. There are 20% of their beds are inpatient beds dedicated to patients who actually have active symptoms. Or they could come over under palliative care to a palliative care bed. And that's for anybody with symptoms, anybody for planned ventilator liberation, and anybody with a planned liberation from VAD or other assist devices. So what else is new? I think many of you already know that we had two consult teams up until August of this year, where we added our third consult team. Our two consult teams used to see about 1,300 to 1,400 patients a year. And we added the third consult team really to focus on two areas, on medical oncology and in the surgical ICU. So you may see us or our team around in the ICU. Feel free to ask them. They're there to really help with the communications about goals. We also started a supportive oncology program in Wittenberg. That started in April, so we have a provider and now a nurse who's there to see cancer patients and to help the transition between inpatient and outpatient care. We have an arts and creative writing therapy program, and we have pet therapy, and that's all in addition to our massage and yoga therapy. So I want to sort of show you some artwork that our patients have actually done. So the top two, interestingly enough, were all patients who actually have decided that they were going to work with the art therapist, and look at the medium they chose. They're pencil and charcoal. And if you really think about what that does, it's a lot of control, right? They feel that the pencil, they can have the line exactly where they want it. They can draw it exactly what they want to do with the pencil or the charcoal. Look at the bottom half. This is progression over time. They were willing to work with mediums that doesn't allow them to have control over everything. And it took time. And it also is reflected in their perception of the therapies and the treatments and getting adjusted to sort of the hospital care where there is a sense that control is taken out of them. So this is the pictures you see here is actually by the same patient over the course of about 3 or 4 days. Went from these antler-like branches to something much softer with fruit, with color, not bare anymore. And her willingness to even work with a medium that takes the control out of what she does was pretty impressive because it actually changes her way of looking at her disease process. And that's the reason why we need the rest of our team. These are hand molds that allows for the interaction between patients and their loved ones. So a lot of times patients may be so sick they can no longer interact with their loved ones. The art therapist can work with them and actually make something together that allows them to have a memory of their loved one and have their loved one participate. This one I thought was very impressive. This one is actually a wife and her husband. Her husband is very, very ill, and look at the definitions of the hand. You can see all the details of her hand, and you lose all of that with his, a reflection of how sick he is. But while the wife was sanding this out, it was actually very therapeutic for her to make this as perfect as possible, something that she can actually keep. This is a piece by our patient, and I thought it was actually very poignant because it points out to stuff that I myself sometimes overlook. And it's titled The Truth. My throat is like sandpaper. Water don't taste like nothing no more. Nothing. The pain on my cord is tolerable. When it reaches my shoulder blade, that's it. Cold sweats, shaking, heartburn, nerves hitting pressure points, that's it. Bruises everywhere, marks from IVs. Here we go, feeling drowsy again, not sleeping, not awake. I'm no poet, this is the truth. They seem very simple things, but they're a source of suffering, and she's reflecting that in her piece. Our pet therapist, Lily. So she actually makes visits for patients who actually like pets and enjoys their company. Our massage therapist. Our yoga therapist. You may be wondering why yoga has a role in seriously ill. And there are actually positions that can actually help patients. You see this gentleman is actually in what we call a T position. So there's a pillow right behind his spine supporting his back and a pillow across the head. And that actually helps him open up his chest. Because then if he actually was leaning back, his shoulder drops back around the pillow. And it actually can help patients who may have difficulty breathing open up the chest. So it's just something to think about. She doesn't have patients hold any position on their own. It's all propped by pillows to make them more comfortable. And she has positions that help with lymphatic drainage, etc. So what are we doing in terms of palliative care education? Sort of something that I wanted to end the talk with is that we are actually educating a lot of the fellows, both in geriatric medical oncology. They spent a month with us. We're seeing fellows from pain service, surgical oncology, and gyn-onc for 2 weeks. We have a primary care internal medicine track residents for 2 to 4 weeks, depending on the individual. ED residents, it's an elective. And third-year medical students spend a week observing what it is that we do. And this is all with the hope that we could actually integrate palliative care early on into the course of the patient's illness. As I emphasized earlier, it's not about calling us the Pall Care specialists, it's about what we could do as a healthcare community to serve the needs of our patients. So I hope I have actually given you an overview of who, what, and why we're doing palliative care, where there are opportunities for surgery and palliative care, and some resources here that are available at Mount Sinai. And with that, I thank you for your time, and I'll take any questions.